to Facebook. So we're delighted to be here today. So we are working in partnership with the Global Liver Institute, who for I think 4 years now have been leading International NASH Day. And so as a special today, we have guest speaker George Mells. Dr. George Mells, who is on our medical advisory board, is also one of our trustees, is one of our regulars here. And we're absolutely delighted to have you with us, George. So good afternoon to you and thank you.
Hello.
And we also have Dr. Tessa Cacciottolo, which is close enough, I'm told. So again, Tessa, welcome. Thank you so much for joining us today. As ever, the whole point of today is about being interactive. So we're looking for your questions. So if you have any questions here in the room in Click Meeting or on Facebook, please do ask your questions. So today has a particular focus in terms of NASH, NAFLD, and PBC together. So what we will do is I will invite Tessa to speak to you. I'm happy to operate the slides, Tessa. So if you just want to tell me when you want the next slide up. And then other than that, I will put you in the warm, safe, fuzzy hands of the PBC community. So thank you.
Robert, just before Tess starts, actually, can I give a little bit of additional introduction to her? Actually,
Yes.
So Tess is one of our rising stars in hepatology. She did a PhD here, really focused on NASH, which we're about to talk about, and she can tell you a little bit more about that. And she's currently working as a clinical lecturer in hepatology, which means that she spends half of her time doing clinical work, currently on the transplant ward, and half of her time continuing to do the research that she started during her PhD. So it's really nice that she can join me today, and hopefully she can tell you much more about fatty liver than I would ever be able to. So anyway, there you go, Tessa.
Thanks, Tess. That's very kind. So I thought we could start off with our slide and talk a little bit about NASH today and what is NASH, and perhaps touch a little bit on the relevance to PBC. So Robert, could I have the next slide, please? So I thought we could start off by going through all these acronyms: NASH, NAFLD, MAFLD. What's all this about? So NAFLD, non-alcoholic fatty liver disease, refers to the deposition of fat in the liver. So as you can see on that second liver there, with fat within it. And NAFLD refers to that deposition of fat, and it is not normal for there to be fat within the liver. And the most important driver of fatty liver disease is being overweight. So when we have, the body's designed to hold fat underneath the skin. That's the place where the body most efficiently stores fat. But when it can't accommodate any more of that fat, the fat spills over and goes off into other organs, including the liver. The liver seems to attract quite a lot of that fat, but other organs do as well, including muscles, including the pancreas, and exacerbates diabetes. And because the liver is not designed to hold that fat in a number of people and over very many years, that will cause an inflammation. And as you can imagine, as happens in the skin, after a long period of time of inflammation, you get scarring forming. And so you get the start of scarring, and eventually that causes cirrhosis. So the inflammatory process is what we call steatohepatitis, or inflammation within the liver, and that's where NASH comes in. And then I think the PBC community will be very familiar with changing names, going from primary biliary cirrhosis to cholangitis, and the NAFLD community is now looking into changing the name NAFLD to MAFLD, or metabolic associated fatty liver disease. And I think we're still within the process of doing that. So if in time you start to hear more and more about MAFLD, that's what it's referring to. Right, could I have the next slide, Rob, please? Thank you. So as I said earlier, in the majority of patients, being overweight is what drives NAFLD. And I think often as doctors, we don't really talk about weight. And when we do, we tend to do it quite poorly. Rather than the next bit. But I think, as you will see on the next figure, which Rob is just about to show us, there we go. Being overweight is actually becoming a lot more common. So if I talk you through the right side of the slide, what I've plotted here is body mass index, which is a ratio of weight to height. So, for example, somebody who's 90 kilograms and is 5 foot tall is very different to somebody who's 90 kilograms and, say, 6 foot tall. And what we can see here in the blue is the distribution of BMI in the UK population 30 years ago. And you can see that the current distribution in red is very different. So as a population, we are getting heavier. And I think because of that, it is more important that we start to talk about weight in a sensitive, non-judgmental manner, and in such a way that we can tackle it from a medical point of view. Have the next slide, Rob, please. And actually, why do we want to talk about weight? Why is it important? It's nothing to do with appearance or cosmetics or even being told off, but actually it's because we are all worried about the complications of being overweight or even obese. And as you can see on this cartoon here on the left, being overweight predisposes to diabetes, predisposes to cardiovascular disease, so heart attacks and strokes, but it also predisposes to non-alcoholic fatty liver disease, or NAFLD, which often goes hand in hand with all of those other conditions. Interestingly, there's also more emerging evidence that PBC is more severe in people who are overweight. And the second thing to say is that one liver condition doesn't preclude you from having a second one. So somebody with a liver disease of one cause is not saved or spared the possibility of a second problem such as NAFLD. So go on to the next slide now. Okay, so I think it's important that we start to understand body weight, the regulation of body weight. And by understanding it, then we can start to think of what we can do about it. So why do people gain weight? Well, at the most fundamental, body weight is regulated by a balance of the food you take in, what you eat, and the energy that's burnt, so the exercise one does. And a lot of that is determined by our environment, and our environment explains quite a lot of that change in body weight, which you saw in the previous slide over the past 30 years. So the food we eat has changed. Our food is much more calorie dense, is much more readily available, and also we exercise a lot less, both at home and at work. And that shift in balance has contributed to there being an excessive energy intake, and that leads to obesity. Now, it's important to recognize also that our bodies have developed highly specific systems to be able to regulate that body weight. And as you can see on the right, it's a very busy cartoon, but basically, I want to make the point that, very interestingly, the brain is the main organ which regulates our body weight. So it receives signals from the gut. So the gut, when we eat, the gut sends signals to the brain about what sort of food we're eating and how much food we're eating. And the adipose tissue, so the fat under the skin, also produces hormones directly in proportion to the amount of fat they are storing. So it's a bit like a storekeeping, if you like. And those signals get sent to the brain all the time, so that the brain has a gauge of what's coming in, what's going out, and can innately, so without you knowing, then determine how much you eat, how much energy you burn. And I think that is a really important concept for everybody to bear in mind. But then what is interesting is that despite all of us having these shared mechanisms and all of us sharing an environment, actually we don't all have the same body weight. A proportion of people lie somewhere in the middle of that curve you saw earlier. But some people are very thin and do not put on any weight irrespective of how much they eat. And some people put on weight very easily. And again, I think that's important, and I'll come back to it in the coming slides. Another thing I just want to mention is that there's now increasing evidence that genes play an important role in the regulation of body weight and in determining where along that distribution you lie, in terms of either being in the middle or being thinner than average or heavier than average. Could I have the next slide, Rob, please? Thank you. So I think understanding the biology of body weight is really important in order to then go on and make those changes we want to make. Because it's important as doctors, but also as patients, to recognize that in dealing with being overweight, most of the time we are asking people to fight their biology and to do that over quite a prolonged period of time. So that's the first step. And I think a lot of the time we tend to tell people off, or tend to be seen as telling people off. And I don't think that this should be the case. I think it should be a conversation between patients and healthcare workers about how best to tackle this problem in a way which can be kept up in the long term. So here are a series of recommendations from the European Liver Association about recommendations we should make for people with NAFLD. And as you will see, all of these are about lifestyle approaches. So being careful about the food intake, being careful about the amount of alcohol that's consumed, encouraging physical activity, and also watching out for the specific type of food that's eaten. And as I always say to patients, people who are overweight and who struggle to lose weight probably have a tendency to hold on to their calories, and it's probably because over a long period of time, people have developed mechanisms to protect themselves from starvation, from there being a famine around the corner. But I think in this day and age, it's quite unlikely that we will face that sort of famine in the next 10 years or so. So we have to be mindful of that, and we have to be mindful that we are asking patients to fight their biology and asking them to do that over the long term. And I think there needs to be sort of a two-way discussion about how best to do that, and a lot of support from all sides. So we move to the next slide now. I just wanted sort of to finish this part of the talk by saying that we talk a lot about lifestyle, and I acknowledge that it's quite a hard thing to do, but of course we need to persevere with that. But there is some light at the end of the tunnel for medical therapy, both for obesity and fatty liver disease. And you will see some very recent publication on the left for semaglutide with 15 to 18% weight loss, which is, I think, quite remarkable and probably one of the better treatments coming on board more recently. It's not licensed yet, there are still ongoing trials, but it is looking extremely promising. And on the right-hand side of the screen at the top, you will see that late last year, NICE has approved liraglutide, which is a relation of semaglutide, for the management of weight loss, even without diabetes in the UK. And I think that is quite a milestone. The other point to make is that some of the drugs which are looking very promising for managing weight, unsurprisingly, are also looking promising for the management of NASH. And so the message here really is, let's take heart. Lifestyle changes are hard. We do need to persevere with them, but there is some light at the end of the tunnel, in that we might be able to help those lifestyle changes with medicines in the near future, I would hope. Thank you.
Thank you very much for that. So we will be inviting questions. So anything you have, we can do the slides again. We can refer to the slides and Tessa can answer any questions that you do have. So as ever, there will be some PBC questions. There will be some fatty liver disease questions, and there may be questions that are pertinent to both. So do feel free to get stuck in terms of providing an answer and any thoughts that you may have. If I may, before we start the questions, I'd like to just raise this topic, because what we work here at the Foundation, and George knows this, is very much about self-management, self-care. And we look at the emotional, the psychological, and the physical aspects of living with a long-term condition. Now, one of the things that we we talk about is the emotional part of the brain. And sometimes when we look at the patient-clinician partnership, and, sometimes the doctor will say, I'm sorry to be the one to say this, but actually you could do with losing a few pounds, which is perfectly valid. It's a reasonable view. clinically it would make sense. But what happens is, as patients, we hear that, not with the common sense part of our brain that's up here that's going, Doc, you've got a point there. What we do is we hear that with our emotional part of our brain and take that on board as a threat, which then inspires an emotional response to that information. So again, it's important to raise our awareness of that and how that we work as humans, because if we have that awareness, then obviously we can try to temper our reactions to that and hopefully take it on board in a helpful way and use that to help ourselves. So I just wanted to highlight that. Meantime, I'm going to come back to questions. So I'm going to fire this at both of you. So Tessa, we're going to go classic old school ladies first, if that's okay. Is there a correlation between weight and itch?
I haven't seen that correlation, even in people who are extreme, very overweight. It's not really been a feature of their syndrome.
Okay, thank you. And George, in terms of PBC, are we aware of anything?
Not between weight and itch, Robert, but what we definitely see, and what has actually been mentioned in these webinars in the past, is that there's a very clear relation. Well, there's an anecdotal relation between what people are eating and itch, and it differs for different people. So for some people, it's a high sugar diet. Refined sugars seem to make itching a lot worse in some people, and in other people, it's a fatty diet which seems to make it worse. So diet, yes. Weight, less clear-cut. And in fact, it sometimes works the opposite way. For people who've got really terrible, uncontrolled itching, that scratching all the time, believe it or not, loses a few calories, and they end up losing weight as a result. So that's not a correlation that I'm aware of either, a positive correlation.
Okay, that's helpful. Thank you. So Tess, I'm going to come to you with a question, if I may. So I guess when we are weighed as human beings, we have different constituent parts to that weight. So, very occasionally there's muscle mass, obviously not the case with George and I, but for others that might be the case. But there could also be sort of, for example, swelling. So maybe swollen ankles or swollen stomachs and that kind of thing. So does that have an impact in terms of what we consider the weight to be, and if that type of weight has an impact on our fatty liver disease?
Yeah. So I think as ever, things like body mass index is devised as a way to, actually it was initially intended to screen large populations or to be able to study things at population level. I think as ever, when we deal or interact with patients as individuals, we need to take everything into account. And body weight, as you say, is composed of everything. It's composed of bone, fat tissue, muscle, and swelling, if that's relevant to that particular patient. So I think we have to take all of that on board. And it is the fat mass that is what is important for fatty liver disease. So, for example, if you had somebody who was an athlete and has quite a lot of muscle mass, that obviously contributes to the weight, but it is a healthier type of weight, if you like. And sometimes we really need to distinguish those specific components of body weight. There are specific tests we can do, such as DEXA imaging or specific MRI scans, but very rarely do we need to do that in the clinic. Equally with swelling, I don't think that actually contributes to the development of fatty liver disease. If anything, it may be a consequence if there is quite end-stage liver disease.
Okay, perfect. That's helpful. Thank you. George, so we're talking about weight, but we're also talking about PBC and URSO. So there's a question in the room, and you're a bit away from your camera, so I'll read it out to you. So someone says, I'm interested to know more about weight problem. I have put on 5 stone since 2018. I'm on 1,000 milligrams per day. Should I be taking more until I can shift this weight?
Yeah, absolutely. Well, it depends. I mean, that's weight gain of 5 stones. I don't know what the starting weight was, and therefore I don't know what the current weight is. But yes, people should always be taking the weight adjusted dose of ursodeoxycholic acid, and it should be a dose of somewhere between 13 to 15 milligrams per kilogram per day. And the clinicians, the patients and the clinicians should be keeping an eye on the weight, so that that dose can be adjusted throughout the lifetime of the patient. That's a very important message, actually, to everyone who's listening. You should be checking every now and again, because our weight does change over time, to make sure that you're still on the correct dose. Some people will have started on 750 because they were pretty light previously, and we gain a few pounds as we get older, and now that's not quite enough. Always worth checking.
Yeah. Okay, perfect. Thank you. That's helpful. So we've had an answer that the starting weight was 10 stone. So I'll sit here with the calculator and I'll work that out in a second. So do bear with me. And again, going back to something that you said, Tessa, in that it's about being non-judgmental. It's about having that honest and frank conversation. And particularly when wherever we are in the world, and today, we've got people from Canada, the US, Australia, and all over Europe joining us today. And again, thank you so much for joining us. But we've all had different lockdown experiences, and many of us have put a few pounds on. And I think it's okay to talk about that in a non-judgmental and supportive way, and be honest and say, look, this is where I am now. Let's be honest about this, and let's try and take myself forward. So again, Tessa, thank you for raising that point. Couple of questions for you now, and I like these. So George is used to this, so we get cracking questions coming in. So my first one: how inevitable is fatty liver disease if you are overweight?
That's a really good question. It is not a given that just if you're overweight, you're going to get fatty liver disease. And it is not a given that because you have fatty liver disease, you're going to get progressive liver disease. So I think one of the great questions to my mind is, why do some people for a particular weight get fatty liver disease? Why do some people for a particular weight get severe fatty liver disease? And why do some people with the same weight not get diabetes, not get fatty liver disease, don't get any heart disease? And I think part of that is probably down to genes and genetics, but also the individual environment. And that is work which I hope to follow up on, and there's an awful lot of research going on. So I can't tell you why, or specifically give you the reason why some people for a given weight get fatty liver disease, but what I can say is that it is not inevitable. And some studies have shown that in people who are quite heavy, so people who are requiring bariatric surgery to deal with their weight, the prevalence of significant fatty liver disease is around 25%. So there's the majority of people do not have that significant amount of liver disease. So it's not an inevitable consequence. No.
Okay, thank you. And again,
can I add?
Please, George. Yeah, absolutely.
I mean, Tess, I think my previous education on this was that actually that also patients don't need to lose vast amounts of weight in order to reverse their fatty liver disease. I mean, certainly my usual practice at the moment is to suggest that people just lose 10%, and that's often enough to change that from fatty liver to not fatty liver.
Yeah.
And that doesn't necessarily turn them into a size 0 catwalk model. And I guess that should be reassuring for people, is that, very often we're not asking them to really substantially reduce their size, just by a little bit.
Yeah. So as you say, the evidence is that 7 to 10% should be sufficient of initial weight should be sufficient. My only problem with that is that advice doesn't really qualify the starting weight. So if you are really quite heavy at the start, probably losing 5 kilograms is not sufficient. So I think we need to, again, tailor a lot of these things to the context. But as I always say to my patients in clinic, losing some weight is better than losing nothing. Actually changing lifestyle and getting moving and changing some of that weight from fat to muscle is also important. So even if the scales don't budge, don't lose heart, keep going with your exercise and doing what you can to be healthier. And in some cases, actually, and you mentioned lockdown, Robert, I think that even not putting on any more weight for a large number of people who struggle with their weight is sometimes a win. So for a lot of people in lockdown, inevitably people have done diets before, and suddenly all that weight they've lost has come back on. Others have been so careful, but because they've been unable to exercise, they've been shielding, haven't lost any weight, but haven't put any on. And I think in that context, that is also a win. So yes, I think there's various things. It's about being healthier, losing a little bit of weight can be sufficient. Even not gaining weight is also important in this context.
Wonderful, thank you. Okay, so I've got two questions. I'm not sure which way to go first. So, okay, so we were talking about kind of weight and the fact that we can lose weight. So, again, how reversible is fatty liver disease? So, do we improve it, or do we get rid of it altogether? And if we don't get rid of it altogether, is there enough of an improvement to make a difference so that we still have some fat in there, but that's actually an okay level to have? Does that make sense?
It does. I'm not sure I can very specifically answer that question, but I think certainly if there's enough weight loss, often we see that things like diabetes improves, for example. That's a much easier one to measure. And certainly you do see that as people's weight comes down, as people's diabetes control improves, you see a much slower progression of liver disease, if at all. Now, it's very difficult to be able to quantify the exact amount of fat in the liver. And I think that's one disadvantage. You're not monitoring ALP and looking at trends. I think often we have very little reward to give patients from the fatty liver side of things. And it's harder to quantify, but certainly I think the overall thinking is that it is possible to reduce the amount of fat in the liver, and it is possible to reverse certainly the early stages of fibrosis within the liver. I think that's fair to say.
Okay, perfect. That's helpful. Thank you. Okay, question. If you are overweight, does having PBC make you more likely, the same as the general population, or less likely to develop fatty liver disease?
Right.
And I'm just going to fire that straight down the middle and see who bites first.
Yeah, well, we can both answer. So my take on it actually is that we don't know that there is an association between PBC and fatty liver. Okay, and if there isn't an association between the two, then it means that PBC patients will have exactly the same risk of developing fatty liver as the rest of the population. Okay, meaning that so having PBC doesn't put you at greater risk of developing fatty liver. But what and again, this is now evidence-free, and Tessa can correct me if she believes I'm wrong here, but my interpretation is that if you do have PBC and you have fatty liver, okay, that's probably going to be worse for you than if you just had PBC or just had fatty liver, okay? So when they do coexist, I believe that they work against each other, all right? And therefore, it is really important, actually, that we don't ignore fatty liver in our PBC clinics. But Tessa will have her views on that because she does a different clinic to me, and we'll see a different set of patients.
No, I agree with you, George. I think it is an evidence-free zone, but I think from we don't have evidence, but from a theoretical point of view, I don't see why somebody with PBC would have a reduced chance of getting fatty liver disease, and just by the chances of chance, probably both at increased risk. One question I have for you, George, is what do you think about the consequences on the fat, on cholesterol, and heart disease if both PBC and NASH were present?
Yeah, this is a question that comes up quite often. So you may know historically we were told that we didn't have to worry about high cholesterol in people with PBC because we believed that they had a particular kind of cholesterol called lipoprotein X, which was actually protective. help to protect people supposedly from heart disease. But actually, we see a lot of patients in the clinic who have got elevated cholesterol, and so the question comes up both from the patients themselves and from their general practitioners: should we be treating this? And I must admit, my view these days, because of the society that we currently live in, my view is that we should be treating that cholesterol, because the chances are that we're actually looking at the multifactorial type of hypercholesterolemia that everybody else in the population has. So my view is treat it as being atherogenic and give them the statins.
Yeah, I definitely agree with you. And I think one issue which often comes up in clinics is, am I okay to have statins if I have liver disease? And I think, certainly from my point of view, the answer is definitely yes. There is very little evidence that liver disease is a contraindication to having statins.
Okay, perfect. Again, that's helpful. Okay. Next question. So somebody with fatty liver disease has been given semaglutide, if I got that really close. Will that have any implications on their PBC?
Well, we don't know yet. But it shouldn't do. It shouldn't do, because they should be working independently. But Tessa, exactly what is the mechanism for semaglutide?
The semaglutide is a GLP-1 agonist. So GLP-1 is a hormone which is produced by the gut, and we think it acts on the brain because there are GLP-1 receptors in the brain, and the exact mode of action is still being researched. The other thing GLP-1 agonists do is that they enhance the activity of insulin, so people become more insulin sensitive. And that's why it is also a treatment for diabetes, but you do not need to be diabetic to gain benefit from the weight side of things with semaglutide.
Okay, and do we know what it does to some of the pathways inside the liver that might be relevant for PBC?
No, I think part of it is the insulin sensitivity, and I don't know if we know that that's relevant to PBC. And then the second thing in terms of the liver is, I think part of that effect may be mediated by weight loss.
Okay.
So safe to take it. Yes.
Okay, wonderful. Thank you very much. Good to know. Okay, so we've got somebody. So what we're talking about, the weight loss and that kind of thing. If you have fatty liver disease or have had it and then have improved your situation, is it okay to use a keto-based diet?
Yes, so I don't think there are any contraindications to ketone-based diets, provided you do it correctly. There is evidence that ketone-based diets are helpful for weight loss, but not really any of the jury's still out as to its role in fatty liver disease specifically. So I think the studies are generally split on a 48-52, 50-50 benefit versus no benefit. So there's not really much evidence for benefit in fatty liver disease, some benefit in weight loss.
Okay, wonderful. Thank you. So I'm taking this question out of order because it's an absolute cracker and it's something I've never thought about. If we're treated for cholesterol, will the cholesterol deposits, particularly, for example, the ones that are around our eyes with PBC, will they disappear or diminish?
Well, not necessarily, actually.
Okay.
So this again, these are very interesting areas, but actually they're not areas that are particularly well researched. Those cholesterol deposits are this will in general will be the lipoprotein X, which I was referring to previously, and that usually results from really bad cholestasis. Okay, cholestasis meaning that there is impairment of flow of bile through the liver. Okay, so those cholesterol deposits that used to be quite common in PBC were really a reflection of really bad PBC, so that the bile wasn't flowing nicely out of the liver, and therefore the cholesterol couldn't get out of the liver, and so it started to accumulate in the tissues. Therefore, what actually works is going to be to improve the PBC, to get the bile flowing properly, and then the patient will be able to start excreting all of that cholesterol again. Treating with a statin may not be, well, with a statin, for example, I mean, there are other treatments for high cholesterol. That probably doesn't really tackle the underlying problem.
Yeah.
It's getting the bile flowing again, which is going to tackle the underlying problem.
Okay, fantastic. If you asked that question, thank you so much for doing that, because that was beyond my awareness as well. So thank you. Next question, if I may. If you have PBC or fatty liver disease, or indeed both, would that be an obstacle to weight loss surgery of any kind?
Fatty liver disease, provided it is not advanced liver disease, is not an obstacle to having bariatric surgery. And in fact, there's plenty of evidence that bariatric surgery improves fatty liver disease, partly because of weight loss, but also we think because there's changes in the way the gut works in terms of hormone secretion. So it looks like the gut upregulates things like GLP-1, which is what semaglutide is trying to do. So I think it's really interesting. It's not a barrier, provided there's no evidence of advanced liver disease.
Okay, perfect. Thank you. And in terms of things like liposuction and things?
There's very little evidence for liposuction. There is the theoretical anxiety about liposuction because you are reducing the fat under the skin, which is meant for safe storage of that excess energy. So theoretically, if you're taking away those cells which are meant to store fat, where is the excess fat going to go? Is it going to go in the liver, in muscle, and elsewhere? So it's going to be, sent to the bad places which we don't want it to go to. So that's theoretical, not much evidence for it. And that's, I think that's as far as I could say. George, if you've got any other thoughts about
not on liposuction, no. Just one comment, with respect to the surgery, the operations for people with liver disease. I mean, absolutely, we're only concerned about operations of people who've got really advanced liver disease. But I guess ideally, any operation should be discussed with the liver doctor before it happens. Not just bariatric surgery, but actually any operation should be just checked with the liver doctor, just to make sure that the liver is in a good enough condition to cope with that operation.
Perfect, thank you. Okay. Wonderful. Next question. So this is quite a detailed one, so I'm going to read it live, so forgive me if I'm staring at the screen. So we've got somebody who back in November was 25 pound heavier, wasn't showing NASH. They've now lost 25 pounds. Their BMI has gone down from 29.9 to 23.9, but their NASH is now showing. So there's a little confusion there as to why that might be the case. So do we know why that would be the case, and are there any implications?
Of course, it's difficult to comment about individual cases, but one thing which I think can be borne in mind is that when people lose weight, that there's shifting of lipid from the adipose tissue, which is sort of, it's called lipolysis is the technical term. So it means that there's sort of dissolution of fat from the adipose tissue, and it may be that for a period of time that does go to the liver. So it could be that this is just a wobble, which will go. But as I say, it's quite difficult to comment about individual cases without knowing.
Absolutely, I understand that. But just if there was a general phenomenon. Sorry, can you give me a little more about what's adipose tissue?
Sorry, adipose tissue is fat tissue, and so the fat under the skin, for example, that is called adipose tissue. So sorry about that.
No, not at all, not at all. Okay, thank you. Okay, George, you're on your own here, solo. Do we know what percentage of PBC patients are overweight?
No. But as we discussed before, PBC doesn't make you different, particularly from the general population. So it'll end up being approximately the same proportion of people with PBC will be overweight as the rest of the population, adjusted for their age and their gender and so on. So I don't know what's the population prevalence of being overweight in the UK at the moment.
Of being overweight, it depends where you draw that line. If you draw it at the BMI of 25, it's probably more than 50%.
Right. So there you go. So
BMI is around 28.
So it'll be around the same. It'll be around the same, around 25, up to 50%. I suppose the only difference is that in certain cohorts of PBC patients, it might be a little bit higher. So obviously, people with PBC are very prone to fatigue. And in some people, that fatigue is really debilitating, and they actually get exhausted. Making even the smallest amount of effort can be incapacitating. And of course, if you're not moving, then you will be at risk of weight gain. So it's probably going to be a bit higher in the people who suffer from fatigue. But for people who are not fatigue sufferers, it'll be the same as the population prevalence.
Okay, sorry, that's helpful. Now, I know you just said that people with PBC are in the main the same as the general population. The chief's not here, but you and I both know that she is aware or has a belief that only nice people get PBC. So
yes, but nice people also gain a bit of weight. I mean, Father Christmas is overweight.
Absolutely. So okay. Just in case there are any kids watching, Tessa, can you confirm or deny that Santa Claus has fatty liver disease?
It probably has 25%.
Okay. Next question. So not anything to do with fatty liver.
We're on the topic. I believe, but again, Tessa can correct me if I'm wrong. I mean, he lives in the North Pole, and the First Nations people of Canada and the Eskimos actually have an extraordinary capacity to eat, for example, whale blubber without having any getting any problems from that. So
that's really interesting. Is you just wonder if they're burning more fat?
Well, maybe they are, but I'm going to suggest that actually he's absolutely fine and does not have fatty liver disease.
Fantastic. Right. Okay. So there we go. Right. So now that we've done the serious part of today's conversation, so we thank you both for indulging that nonsense. So we have a PBC question now. So this is unrelated to fatty liver, but it's an important question, so I'm going to ask it. So again, we're very much aware we can't give individual advice, and this is more about medical information than medical advice. But we've got somebody, and this is again a common feature. So they're alarmed by the state of their gums and the fact that they've got crumbling teeth. And I wish the chief was here because she can speak to that with, again, some experiential knowledge. But George, is there anything you can say in terms of so, for example, Sickle syndrome and the issues that people have when they have PBC and sometimes issues with their teeth?
Yeah, no, it's. I mean, unfortunately, I can't offer any particular advice to the person who has this problem. But what I can say is that this is exactly what people need to watch out for. If you have Sickle syndrome, if you've got secondary Sjogren's and you've got dry mouth, then you need to take extra care of your dentition, of your teeth and your gums, because saliva has a very, very important role in essentially washing our teeth. Washing our gums. It's got lots of antibacterial components to it. And therefore, if you're not producing saliva, then you are at risk of caries, of gingivitis, and so on. So for people with PBC who've got dry mouth, this is exactly why they need to take extra care to keep saliva flowing, sugar-free mints, sugar-free chewing gum, for example, using the artificial saliva, but also having those regular dental checks just to make sure that their gums and their teeth are staying in good health.
Okay.
Really important point, yeah.
Okay, thank you. So we've got a question. So it was the father. So it's an experiential question. They were given statins following a heart attack, and then liver enzymes rose to nearly 4 times the level. When they came off the statins, the liver enzymes then returned to normal. Is this a feature? Is this something we should be kind of keeping an eye on with our liver clinician?
So I think generally when people get started on statins, it's fairly common practice to check the liver enzymes a few weeks later. I think most GPs will do that. And we know that it is some individuals, irrespective of whether they have liver disease or not, will react in that way. But there's no way to predict that. And having liver disease doesn't make you, at least the evidence would suggest, doesn't make you more likely for that to happen.
Okay, perfect. That's really helpful. Thank you. Okay, so here's another cracking question, which again, I'm just going to fly straight down the middle and see who wants to grab it first. So how can you tell if you have both PBC and fatty liver?
Yeah, that's a difficult one, actually. It's difficult. And it's becoming more and more of a problem. So we often have to rely on, in my clinic at least, and then Tessa can say how she approaches it in her clinic. But we often have to rely on lots of different sources of information. The ultrasound is really useful, okay? Because if the ultrasound report says that the liver is echogenic, producing a lot of reflections, that's a clue that there might be some fatty liver. So that's a useful piece of knowledge. And then the blood tests can be quite helpful, because in people with pure PBC, we expect the alkaline phosphatase to be raised. The alk-phos is one of the liver enzymes, and that's the one we expect to go up in PBC. We also expect another test called the alanine transaminase to go up. All right, but we don't expect it to go up that much. And if you see it, if it's a bit higher than you would expect it to be, especially in the context of somebody who's got an echogenic liver on their ultrasound scan, especially in the context of someone who is overweight and may have the metabolic syndrome, then this gives us a clue that we're probably dealing with two problems rather than just one. But it's not that easy. You have to take lots and lots of evidence to try and work it out. And really, the only way that you could be absolutely certain would be to do a liver biopsy. But that's quite an invasive way to draw that conclusion. How would you approach it in your clinic?
Yeah, no, George, I think it'd be very similar. So, as we said earlier, sort of being overweight is even more common, which means that fatty liver disease is more common, or having fat in the liver is common. And I think we always take the view that we need to make sure there's no other liver disease going on at the same time. So we will always check the anti-mitochondrial antibodies, for example, to be a little bit more sure that there's nothing else going on or nothing else we could be treating in conjunction with fatty liver disease.
Okay.
And so, as you say, we would look for anti-mitochondrial antibodies, look at the ALP, which is less commonly elevated in fatty liver disease, though not necessarily. It can sometimes be elevated purely because of NAFLD. And again, we have less positive ways of definitely diagnosing fatty liver disease, but we would be looking for evidence of fat on the ultrasound, so an echogenic ultrasound, exactly as George said.
Yeah. Okay, so George, I did come to Tessa with a definition earlier. So when you talk about echogenic, what does that mean?
Well, echogenic just means that that the ultrasound is reflecting back a lot, basically. Okay. Because when you do an ultrasound, what you're actually doing is you're the way you capture the image is from a reflection of the ultrasound wave that you've thrown at the liver. So you're getting it's reflecting more than you would expect it to, and so it's echogenic, and so that one of the causes of that is fatty liver. But it's just the ultrasound appearance, basically. Yeah.
All right, that's helpful. Thank you. On the subject of echogenic, neither of you have mentioned either Fibroscan or CAP scores. Are those helpful or not particularly?
Well, for me, I mean, we do plenty of Fibroscans, but what the Fibroscan is telling us usually is how much fibrous tissue, how much scar tissue there is in the liver. In a condition like PBC, you have to be a little bit careful. If the PBC is really badly controlled, and sometimes it is when you first meet the patient, but settles down with treatment, then you can have what's known as a cholestatic liver, which is full of bile. It can be very inflamed and packed with inflammatory cells, and that means that that your Fibroscan will give you an artificial measurement, a slightly inaccurate measurement, so you'll want to repeat it later. But really you're doing it to measure the amount of scar tissue that's there. It's not going to tell you how much fat is there. Yeah. If you want to try and measure fat and scar tissue, there are some other techniques. Tessa will know them better than I do. But for example, an MRI elastogram will give you a better idea about how much is fat and how much is scarring.
Okay.
Yeah, so we certainly use Fibroscan routinely in the fatty liver disease clinic in order, exactly as George said, to determine the degree of scarring. I think that's quite important in terms of staging somebody, in terms of how far advanced the fatty liver disease is, particularly because often people don't know they have fatty liver disease and have had it for a large number of years, and it's quite hard to know where along the spectrum of how advanced liver disease is from blood tests alone. So we do use Fibroscan routinely in order to determine how much scarring there is. CAP scores are also useful in terms of quantifying the amount of fat, and there are some scores which have been developed, like the FAST score, which takes the CAP score into account. What is limiting more so for the CAP score, but also for the Fibroscan, is the availability of the technology in different hospitals.
Right. Okay. Thank you. And in terms of so when a Fibroscan and the CAP score is used to read for a fat percentage, is that fairly accurate over the piece? So I know Fibroscan, for example, has not been validated yet in PBC. So has it been validated in fatty liver disease?
Yeah, Fibroscan has been extensively validated in fatty liver disease, and so it's probably why we use it more routinely than you would in PBC. And what is also helpful is that there are quality metrics, so we can tell whether a reading is valid or not. There's more evidence now into the development of the larger probes. So initially, when we had the smaller probes, particularly for fatty liver disease and people who are overweight, there was the problem that the distance between the skin and the liver was too big to give reliable readings. But the machines have since, or the company has since evolved the technology with better probes, the larger probes, which are more appropriate for people who are heavier. And so again, we are getting more reliable readings through Fibroscan.
Yeah, perfect. Thank you. So I thought we'd got to the end of the questions, and we've had a couple of fire in. So very, very quickly. So we've had somebody ask about bile stones. Now, I don't know if they mean bile stones, if bile stones are gallstones. I'm not quite sure. So they've had bile stones removed from the bile duct 3 times, but they have no gallbladder. Is that related to PBC? Again, not specifically, but in general terms.
That's quite an interesting question. It's probably not. Probably not.
Okay.
But there are some disorders that could contribute to the development, that would explain recurrent gallstones, bile stones, and might contribute to the development of PBC. But as a general response, no, the two are not likely to be linked to one another. The PBC will be one disorder, and the recurrent stones will be the result of another disorder.
Okay, perfect. That's helpful. So I'm reading this question out here. So somebody's got high cholesterol. So this is a US patient. So I know the units are different, but so George, hopefully you're, or Tessa as well, hopefully you're au fait with American measuring system. So we've got 300 is the high cholesterol score, high LDL of 280, normal triglycerides, but an HDL of 177. I have no idea what any of that means, so I'm hoping you do. So the hepatologist confused, the cardiologist is perplexed. Calcium heart test shows no blockages. Can this be a thing that PBC is causing? Or what kind of questions should the patient be asking next?
You start. Okay. So it sounds like, I mean, I'm afraid we use different measurements here, actually. So those are not numbers that I'm familiar with. But it sounds like the bottom line is that it's a high total cholesterol and it's a high LDL cholesterol, okay, but a normal HDL. The person who's written in may have to correct me on that, but that's the interpretation I'm getting. If that is correct, if I have interpreted correctly that it's high total and high LDL, then yes, that could be explained by the PBC, okay. And if they wanted to be absolutely 100% accurate about what the cause of that elevated LDL cholesterol is, there are ways to do it. The lipidologist, and there will be a lipidologist somewhere in the vicinity, would be able to do some very sophisticated tests to work out what the different types of LDL cholesterol are. And then they'll know whether it's definitely the PBC causing it or whether it's part of metabolic syndrome. And that can sometimes be important because that can influence what you do about it, basically. But yes, there are ways to tease it out, but they wouldn't be routine tests. And I can certainly see why the cardiologist would be interpreting it one way and the hepatologist would be interpreting it another way.
Okay, that's helpful. Thank you. So I'm going to apologize to everyone who's attending today, because what I didn't ask was, or didn't say, what is a CAP score? So again, Tessa, could you maybe offer a little insight to that, please?
This CAP stands for Continuous Attenuated Parameter, which doesn't really tell you much about what it does. But in short, it is a measure of fat within the liver.
Okay, perfect. Thank you. And last question before we move on to George. Is NAFLD common with people with psoriasis or psoriatic arthritis?
No, but I can see where this question might come from. So again, the fatty liver is independent, or based on the limited evidence that is available to us. Remember, in medicine, you can never say that there isn't something. You can only say that there is something. Based on the evidence available to us now, psoriasis and psoriatic arthropathy are independent conditions from fatty liver. Okay, but where these become relevant, where the two become relevant, is that occasionally we have to treat psoriasis and psoriatic arthropathy with a medication like methotrexate or a related medication, leflunomide or something. And these are medications which historically we've associated with scarring of the liver. Okay, and that scarring of the liver that comes from methotrexate may happen faster in people who've got fatty liver. So you can see how, because the fatty liver is so important in that context, how we might have ended up thinking, hang on, this condition is more common in these patients. It probably isn't that they're related to one another. It's just that the fatty liver is that much more relevant in this context.
Wonderful. That's really helpful. Thank you so much. So, George, I'm going to hand over to you now just to close off in terms of the slide with the PBC audit. Before I do that, I'm just going to say, Tessa, thank you so much. That was fascinating. So thank you. Before we go over to George, is there anything, because you know that moment where you think, oh, I should have said that. So is there anything that you kind of got on the tip of your tongue that you wish you'd said in one of your earlier answers?
No, but I think I just want to pick up on what you said about discussing weight, and I think I'm very much on the case with my colleagues all the time about sort of being more empathic in the way we approach talking about weight. And I think that the change needs to come from both sides, and so I would very much encourage any patients listening to this to start to think about weight perhaps more from a medical point of view, and to perhaps trying to be less emotional so that we can actually together be able to tackle that problem. But thank you for having me. It's been an absolute pleasure.
Oh, pleasure. Thank you so much. Okay, thank you. George, I'm going to come to you now, so I'm going to bring this slide up for you to discuss.
Great. Thanks, Roy. This is related to the, I don't know who was listening in to the webinar that I did last time, but I said I presented my good news at the last webinar was the fact that we were doing this audit of PBC in the UK. And Robert, I mean, as you know, I think this is really exciting, actually, that as an entire country, we've decided that this year we're going to sort this problem out, right? We're going to sort out these two problems. Number one, that people are not either getting onto the URSO, or if they're getting onto the URSO, they're not getting the right dose of it. We're going to sort that out. And then number two, that anyone who is in need of second-line treatment, this year, we're going to find them and we're going to make sure that they are referred for their second-line treatment. So this slide here is just the good news of the week. Each blue area means that region is now participating in the audit. And you can see that the UK is slowly turning blue. I mean, anyone who's in the UK, this is not a political statement, by the way. I mean, we could shade it red next time if you prefer. But the point is that but most regions of the UK are now participating in this audit. And what we really want is by the end of this year, we want no more brown areas left. It's all got to be shaded in and indicating that we're solving these two major problems that still exist in the UK and probably in other parts of the world, but certainly they exist here.
Perfect. Thank you, George, for sharing that. So I'm just looking at the map and I'm observing that Cambridge is dark blue and Oxford is light blue. Is there any message in there from the
yeah, well, I know we've somehow we've reversed it. I guess it means that Oxford has invaded and taken over Cambridge, which is a disaster.
Indeed. So, if another question is, it says, where is George based? So, just to clarify that both Tessa and George are based at Addenbrooke's at Cambridge, which is widely regarded as a centre of excellence. It's a transplant centre and has been involved in many liver initiatives over the years. So, again, George, Tessa, thank you both very much for joining us. It's been an interesting session. It's been a different session. I hope it's been helpful. If you still have questions, again, as ever, do contact the foundation directly. Other than that, we shall look forward to a normal session next Thursday. And again, thank you for joining us. Thank you to the Global Liver Institute who have supported us and who have partnered us in this initiative today. And all I can say to you is thank you both to our doctors, to everyone watching, and I'll leave you all in peace. So thank you.
Well, thank you, Robert. Thank you. Bye.
Pleasure. Bye-bye. Take care.
Just leave.